Hello guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, we are still doing anesthesia. So as you have seen, yesterday I did post and I did promise that today, after my call, I was on call yesterday. After my call, I was gonna come back and tell you about how my call went and discuss the patients that we did last night. So I was in Gen Search, so I was in a theater where they do Gen Search cases. So I had a nice call, guys. I had a nice call because we only did 2 cases. This is it was my 5th call yesterday. I'm also on call again today from 8 in the evening until 11 tomorrow. So most of the times we will do about 6, 7, 8 cases a night, but for some reason the world decided to forgive us and then we only did 2 cases. So we are going to discuss those cases. This is practical, guys. This is practical. It's what we did. And I would encourage you. I think this is the most important tutorial that you're gonna have, or the discussion that we're gonna have in anesthesia. So I know how difficult it is to sit and study anesthesia and still not even imagine how these things are actually done. So I hope this video is just going to help you to bridge that gap, especially for students. So when you talk about anesthesia, the approach to a patient who needs to go to theater from the anesthetic point of view, there are 3 things that we need to have in mind. So let's say the approach. So this is an approach to a patient that needs to be operated. What the anesthetist needs to do, the duties of the anesthetist. So let's say you are an anesthetist. The surgeon calls you and say, look man, I've got whatever case. I've got an amputation that I want to do. I have acute abdomen that I want to do. I have an ectopic that I want to do. I have an abscess that I want to do. The approach would be, so guys, we are going to talk about the 2 cases that I saw, but I want you to understand things on a broad context. This thing of being to understand things in patches, it has got this ability to make you to forget things and not understand what fits where. So understanding things on a broader context helps you to be able to fit everything where it's supposed to fit. And as you go, you just build on that, Okay, so the approach is pre-op assessment. Pre-op assessment, intra-op, and post-op. So pre-op assessment, in many places they call that pre-meds, but if we are strict in our terminology, pre-med is a component or is part of pre-op assessment. So when someone asks you what's your approach to this patient, they give you a scenario and then they ask you what is your approach to this patient or to this case. These are the things that they want to hear. What are you gonna do pre-op? Okay, you'll tell them, okay, pre-op, I'll do A, B, C, and D. Intra-op, this is what I'm gonna do. These are the drugs that I'm gonna use, and this is the airway management technique that I'm gonna apply on this patient. And post-op, this is where they will be managed, and these are the things that are gonna be done post-op. That's a complete plan for this patient. I know as students we are always anxious to know what happens intra-op and actually forget that anesthesia starts pre-op. I'm going to talk about pre-op assessment briefly. Obviously, forgive me if I leave things out, but I'll try to tell about most of the things. So pre-op, a pre-op assessment, you can have a scenario whereby the case is an emergency, or you can have a scenario whereby the case is just an elective. Emergency means that the patient needs to be operated now. That's emergency. And the surgeon wants to operate that patient now to save life and all of that. But elective, it means it's a planned procedure. Even if it's cancelled today, it won't be the end of the world. It can still be done tomorrow and things like that. Broadly speaking. So when you talk about pre-op assessment, it's always tricky with emergency situations. So let's talk about elective. We are gonna come back to emergency. So with elective, a pre-op assessment, the first thing is the history. When a patient is gonna be done, part of your history is to know if the patient knows about what they have and what kind of operation they need to be done, and also whether they've signed the consent or not. And as you go down with your history, you want to know if this patient, the most important thing here is the past medical history. Why is it important? The past medical history of the patient, when you've got things like bronchial asthma, you want to know about that, because asthma affects the airway, and when you take a patient to theater, one of the concerns is the airway. So you want to plan for this patient properly. You want to know that they've got asthma before you take them to theater. And when you know that they've got asthma, you anticipate a difficult airway, especially if they are not controlled. If they've got COPD, let's say if they've got any lung disorders or lung pathologies, you want to know about that, especially your airway. Both of those are your airway disorders. You want to know if they are hypertensive. You want them to be controlled. All medical conditions must be controlled before the patient goes to theater. You want to know that they are controlled if they are hypertensive. And you want to know what drugs are they taking. Drugs that tend to give a problem intra-op are your ACE inhibitors. because that's why they need to stop those drugs a night before they go to theater, because in theater they cause blood pressures to drop. Remember, anesthetic drugs, they cause the blood pressure to drop. Now it's even worse when you've got an antihypertensive that is dropping the blood pressure as well. So I'm not gonna mention everything, guys, obviously, but yes, you also want to know if they're diabetic. The way of asking these questions, you're not going to ask them, are you diabetic? Do you have asthma? Do you have COPD? No, just ask them, are you taking any medications? Some of them will ask you about medications that they take for pain. Then it means that you need to explain, are you taking any, is there any kind of medication that you have to take, you must go and get from the clinic or from your doctor every month? That's usually your chronic medications. If they've got to go to the doctor or to the clinic every month to go and collect, it means that's a chronic. So that's where you want to dwell. So you don't have to ask them one by one. So that's the past medical history. And when it comes to past search history, the past search history is not very important for the anesthetist, but it gives you an idea if the patient has been exposed to anesthesia before. Exposure to anesthesia. And if they say they have had an operation, you want to know, you're going to try and describe, because patients might not understand. Did you get an injection on the back? That would be spinal. And were there any problems with that? Then they will tell you. Or they'll tell you, no, I don't know, they just told me that they're gonna knock me out and then I'm gonna be sleeping, and then that's a GA. Now you're gonna ask them, were there any complications with that? So were there any complications with that? And obviously, another medical condition, another thing that you want to ask is, if a patient looks to be very obese, they look to have a short neck, you might want to ask them about apnea. And the best way of asking if the patient has got a sleep apnea is, do they snore? And some patients might tell you that, oh, my wife always complains, or my parents always complains, or maybe the relative will be there to tell you that, no, this one always snores, and his or her snoring wakes me up, things like that. And then you can try to describe what sleep apnea is. Sleep apnea is someone who, so it's those brief moments the patient is sleeping and then they sort of like stop breathing for a moment, for seconds, then they wake up. So that's sleep apnea. I should have written sleep apnea. Obviously, guys, there are other things there. There are other things. I cannot cover everything, and especially I didn't even prepare for this part of the talk. So the past surgical history will be that, and also if there were complications, like I had to go to ICU, I had a reaction to a drug, I had to stay in ICU for some time, and they say that I bled a lot, that kind of a thing. And also, when it comes to past medical history, you want to know if there are any drugs that they use, like anticoagulants. Maybe we can just put that there as a drug history. This drug can be both medical or non-medical drugs, and also anticoagulants. And then they'll be using anticoagulants because they've got some kind of, maybe they've got DVT, they've got whatever. So anticoagulants, and also bleeding disorders in the both in the family and also the patient, bleeding disorders. And then let's get to to what's the thing? Family history. Family history. Passage college. Past medical history. Drugs. So when they ask you to go and do a pre-op assessment, these are the things that they want you to talk to the patient about. Like I said, the history part is the patient understands why they are going for theater. They understand what the condition, what condition they have. They understand what sort of procedure the surgeon wants to do, and the consent, and the issue of the last meal becomes very important when it comes to emergencies. We're going to talk about it just now. So, anticoagulants. Anticoagulants. And also, so when it comes to past family history, past family history, family history. So with family history, you want to know about if there's any member in the family who maybe passed away or demised intra-op or post-op, maybe due to an anesthetic complication, or if they've got things like conditions like malignant hyperthermia, which tends to run in the family, and also scolding apnea. Then the patient also will tell you if they had complications with that previously, if they've had an exposure to scolding apnea. Is a real thing that happens and is a problem. So yes, bleeding disorders in the family and that type of a thing. I can't think of any other things right now. And then another thing that you wanna talk about is allergies. What kind of allergies does the patient have? Remember, eggs and peanuts, the story around eggs and peanuts with propofol, and and also other allergies. If a patient tells us that I'm allergic to Brufen, it means you won't use Brufen post-op, or you won't use, or if there's still that I've got allergy to, a patient can have an allergy to, they can have allergy to any medication. Say they've got allergy to a certain antibiotic, it means that you must take that antibiotic out. You must not prescribe that antibiotic for that patient. So it's all about avoiding whatever that the patient says I'm allergic to there. And pre-op assessment. I'm not sure if I'm leaving anything out at this point, but I know you guys are gonna go and read about pre-op assessment as well, and you're gonna add more. Okay, so that's your history. It's pre-op assessment, but the history component of it. Now, what's the difference between emergency and elective? With emergency, yes, you are gonna run through these things very fast because it's an emergency. But now, yes, you're still gonna do all of these things, but the issue of last meal becomes more important. The last time the patient ate. With these ones, it's not really an issue because you are gonna go to the ward before they come to theater, and after you have done your pre-op assessment, part of your plan would be to tell the nurses to put this patient on the fasting protocol. Maybe we're going to talk about it sometime. Fasting protocol. How do you fast patients before they go to theater? So the last meal becomes important here because it's going to tell you whether you have got to do a rapid sequence induction or not. But many doctors, if a patient is in emergency, they'll just always do rapid sequence. I mean, you cannot trust patients. You just cannot trust patients. They can say, I've not eaten. Some, maybe because of the accident, they've even forgotten, or some cannot even talk. So most of the time, they just do rapid sequence induction. So when a patient that has been starved, and you know that the patient has been starved from the ward, you only have to do a rapid sequence induction. Guys, let's meet on part 2 of this talk. We're already 20 minutes into this one. Thanks for watching.